Welcome to the third part of this presentation on accountable care organizations. Now we will shift gears to look at ACOs from the perspective of healthcare providers, and we'll consider three fundamental questions. First, what an ACO or an organization of healthcare providers forming an ACO would need to do to succeed. Second, how an ACO can go about reducing overutilization in practice. And third, we'll also look at the healthcare fraud and antitrust legal issues ACOs may face. So how can an ACO reduce costs and achieve while still achieving high quality? Well, we've talked about things like the patient-centered medical home and good access to primary care. And we've also discussed care coordination and exchanging health information with electronic health records and how those can prevent follow-up care from falling through the cracks. And these can reduce reliance on more expensive care like the ER or inpatient hospital admissions. And this is certainly a start when it comes to reducing costs. But to really put a dent in costs, an ACO will also need to do something to tackle the problem of overutilization caused by so-called provider or physician-driven demand. The following excerpts from Dr. Gawande's The Cost Conundrum article provides a clear example of overutilization caused by physician-driven demand. And this is what an ACO would need to try to tackle. In this article, Dr. Gawande is discussing what he heard from physicians in McAllen, Texas, a community with some of the highest health spending in the country. As we read it, think about how could an ACO prevent this type of thing from occurring? General surgeons are often asked to see patients with pain from gallstones. If there aren't any complications, and there usually aren't, the pain goes away on its own or with pain medication. With instruction on eating a lower fat diet, most patients experience no further difficulties, but some have recurrent episodes and need surgery to remove their gallbladder. Seeing a patient who has uncomplicated first-time gallstone pain requires some judgment. A surgeon has to provide reassurance. People are often scared and want to go straight to surgery. Some education about gallstone disease and diet, perhaps a prescription for pain. In a few weeks, the surgeon might follow up. But increasingly, I was told, McAllen surgeons simply operate. The patient wasn't going to moderate her diet, they tell themselves. The pain was just going to come back, and by operating, they happen to make an extra $700. So how could an ACO address this type of overutilization? Well, it could first implement a patient-centered medical home or a PCMH to hopefully make the primary care physician a natural first stop in receiving care. Second, it could coordinate care so that conservative treatment before surgery would hopefully be more available and more effective. And finally, it could offer financial incentives for providers to use more cost-effective treatments. Let's talk about each of these strategies and how they would apply in this example. So the patient-centered medical home. In the scenario with the surgeon and gallstones, one might wonder why the patient is first seeing a surgeon. If change in diet and pain management is the best conservative treatment, it might be better to see a primary care physician or a dietitian. Surgeons are trained to be very good at cutting people open and fixing them, and they're very good at that. But other providers may be better situated to help the patient change behavior. And an ACO can't really implement gatekeeping, requiring that the patient first see a primary care provider, but with an effective PCMH making up part of the ACO can make primary care a natural first stop. The idea with a PCMH is for the primary care physician to be the quarterback who coordinates the care on a range of issues. So the patient has a clear home when it comes to coordinating different issues, a variety of issues. And some characteristics of a PCMH include email consultations where the patient can shoot their doctor an email and get a response. Same-day appointments and office hours that go a bit later into the evening. Someone who has a deeper knowledge of the patient's medical and social history and an ongoing relationship. They would be able to know whether this patient is going to be successful in changing their diet or how likely they will be. And access to a broader range of referrals and resources. So let's think about how a PCMH could prevent the waste of an unnecessary gallbladder surgery. With an email consultation and same-day appointments, the aim is to make it so convenient that the patient will choose the primary care provider as a first stop, rather than going straight to a specialist. And if the primary care provider has a good understanding of the patient's medical and social history, they are in a better position to judge whether conservative treatment or more aggressive treatment will be appropriate in that particular case. And with the PCMH, an ACO would hopefully facilitate good care coordination. If the primary care doctor recommended conservative treatment, an ACO with a good EHR that exchanges data could allow better care coordination. Specifically, the ACO could see whether the patient actually got in to see a dietitian or could see whether the patient actually filled the prescription. They could also see the notes from the dietitian visit and make sure there is appropriate follow-up care. So rather than just assuming that the patient is not going to moderate his or her diet, the PCMH can actually provide the patient with resources to succeed and track whether the patient complies. And the EHR will hopefully provide good evidence-based guidelines and have those integrated into the EHR. So if conservative treatment appears it may not work, the doctor could refer to good evidence-based standards for when surgery is appropriate. But this model does raise some questions about the role and work of specialists. As the population gets older and lives with more complex conditions, even in a prevention-focused health system, there will still be a demand for specialist services. But it creates some questions as to what an ACO will need to do to get specialists to buy in if the system may be focused more on reducing reliance on specialists. So as we covered before, an ACO gets a share of the savings it achieves, and providers may get a bonus for keeping surgeries or surgery referrals within evidence-based parameters. But providers also still get the fee-for-service payment. So looking back to Dr. Gawande's example, the surgeon would be able to get an extra $700 by opting to operate. And the question becomes, are whatever bonuses or incentives the surgeon may get for providing more cost-effective care, are those sufficient to counter the proverbial $700 extra the doctor gets for doing the operation? Some initial research suggests that with the current structure of ACOs, the financial incentives probably will not be sufficient in ACOs that consists of providers in independent practices that form a virtual network or joint venture just for the purposes of the accountable care organization. So given that there is the potential for fee-for-service payment for ACO providers as well as bonuses, the literally billion-dollar question becomes whether ACOs can structure incentives such that providers will forget about the proverbial extra $700 and just focus on providing the most cost-effective care. As some initial economic research suggests, the more fully integrated ACOs consisting of salaried and employed physicians will be more effective in controlling overutilization. Specifically, the study by Franson and Rebizer in 2015 found that the financial bonuses alone that an ACO offers will be underpowered to get providers to change practice patterns. In other words, whatever payment or bonus the surgeon would get for not doing the surgery would not be high enough for him or her to ignore the proverbial $700. But if you have physicians that are employed by an integrated health system, these physicians may have a salaried compensation agreement such that the physician wouldn't have a financial incentive to perform surgeries that aren't really necessary. And the system could be set up so that part of the physician's job description is to provide care coordination, rather than just seeing patients and performing treatments on a fee-for-service basis. Franson and Rebizer explained this as follows. A doctor, for example, who spends more of the day in meetings devoted to making care processes more cost-effective loses the opportunity to see more fee-for-service commercial patients. For physicians who are employees, an obvious way to reduce this opportunity cost of effort is via job design. The employer can simply mandate that the physician has to spend certain hours on process improvements and cannot see patients during that time. Now, anyone who's worked with physicians, particularly Idaho physicians who value autonomy, would hesitate to use the term mandate. I think it would only be an economist who would say that. But let me provide you another example to illustrate how this may work. So let's use the example first of an ACO that consists of a highly integrated system where primary care physicians and specialists are all salaried employees of the health system. Think of something like the Kaiser Permanente or the Mayo Clinic. And a patient with frostbite gets treated by a primary care physician. Or this could be an urgent care setting, and it could be a nurse practitioner or a physician assistant. And this primary care physician is about 80% sure, let's just say 80% sure, that this frostbite is not deep enough to cause nerve damage, that there's no risk of severe infection, but the provider wants to be more sure. In such an integrated health system, there may be dermatologists available for immediate consultation. So the physician could just call up a dermatologist, explain the symptoms, and if the clinic's all high-tech, maybe they could connect with an HD video, and the dermatologist could actually see the skin, see where it turns red to the touch, and even if the clinic is low-tech, maybe the dermatologist is sitting in her office down the hallway and could just pop her head in and take a quick look at the patient, even though this wouldn't constitute a billable visit. But they don't care. They get paid a salary. So in just a few minutes, the patient could be on his or her way if the PCP was correct and there wasn't risk of nerve damage. And if the primary care physician was wrong or was incorrect and the dermatologist recommended that the patient needed additional treatment, they could get the patient set up with that right away. Now let's consider how that might play out in a more loosely structured ACO consisting of a so-called virtual network of independent practices that formed a joint venture just for the purpose of creating an ACO. So the primary care physician is still in this hypothetical pretty sure, about 80% sure, that the patient is okay, but wants to be sure. The primary care physician may have some financial incentives to avoid unnecessarily referring patients to specialists. But here, the primary care physician really isn't sure, so a consultation with a specialist may be warranted. With a lot of loosely affiliated independent practices, there may not be a dermatologist available for immediate telephone consultation. So the primary care physician would probably just direct the patient to make an appointment with a dermatologist, which would result in the dermatologist billing for the visit fee for service and driving up costs. Because this dermatologist, we'll call him or her Dr. Derm, has his or her own independent practice that was developed with a fee for service model, it would be hard for this doctor to set aside substantial parts of the day just to answer questions and to help coordinate care. Think about it. Dr. Derm probably has his or her own payroll to make, an office lease to pay, malpractice insurance premiums to pay. To make sure that he or she can cover costs, Dr. Derm will need to focus on providing fee-for-service visits on a pretty consistent and regular basis. They probably won't want to bank too much on the possibility of potentially getting a shared savings bonus to cover these at the end of the year to cover these ongoing costs. And for this reason, I think you may see more integrated ACOs being able to control costs more effectively. So now let's consider some legal issues that ACOs may create or that they may face. First, there are issues related to healthcare fraud and abuse laws, including the Stark self-referral law and the anti-kickback statute. Second, there may be antitrust concerns. The ACO model encourages greater coordination and integration between providers, and this may lead to higher market concentrations that may be in violation of antitrust laws. In this regard, I would like to take just a few minutes looking at the Salzer and St. Luke's antitrust lawsuit in a few slides. First, I want to provide a really brief overview of the two federal healthcare laws that relate to what ACOs do. The first is the Physician Self-Referral Law, also called the Stark Law, after Congressman Pete Stark, who drafted the law back in the 1980s. And in simple terms, the Stark Law prohibits physicians from referring Medicare or Medicaid patients or patients from any federal health program for services that the providers have a financial interest in. And the classic example is the physician who owns a clinical lab and orders lots of tests from that clinical lab that he or she has a financial interest in, and then bills Medicare for those services. And this is exactly the concern that caused the Stark Law to be enacted. So if a physician has an ownership interest in a clinical lab, he or she cannot refer his or her own Medicare or Medicaid patients to get tests from that lab. And as we'll talk about in this class, there are many, many, many exceptions that apply to these laws, including allowing physicians to refer to hospitals in which they have an ownership interest or employee relationship with. The next law is the Anti-Kickback Statute, and it prohibits anyone from giving or receiving anything of value with the intent to induce referrals for Medicare or Medicaid patients. And the classic examples of violations would be, first, a skilled nursing facility or rehab hospital paying the discharge planner at a hospital a certain amount of money for every patient that got discharged to that facility. Another classic example would be a drug company giving a physician who meets a certain quota for prescribing the pharmaceutical company's medications a free trip to Hawaii to attend a medical conference. Again, there are many situations that if set up correctly are treated as safe harbors that do not violate the Anti-Kickback Statute. But I hope you can see that the purpose or goals of an ACO is at odds with the Stark Law and the Anti-Kickback Statute. Specifically, an ACO wants to encourage its providers to refer patients for efficient coordinated care within that ACO. So physicians that are part of an ACO clearly have financial relationships with other ACO providers. If they provide cost-effective care, they'll get a shared saving bonus. And ACO professionals may have a financial incentive to direct patients to cost-effective care within the ACO. So the question becomes, would this constitute a kickback in violation of the Anti-Kickback Statute? Well, recognizing this, the Department of Health and Human Services issued administrative rules granting Stark and Anti-Kickback Statute waivers to ACOs if they strictly comply with technical details of the rules. And these technical details are well outside the scope of this class. Suffice it to say that these rules require that lawyers carefully dot all the I's and cross all the T's in contracts and agreements between ACO providers. So now let's shift gears and look at antitrust concerns. A primary concern related to ACOs is the potential for increased concentration in the health industry. Specifically, Section 7 of the Clayton Act prohibits any merger or acquisition if the effect of that merger or acquisition may be substantially to lessen competition or to tend to create a monopoly. So if you have all of the healthcare providers in town consolidating into a big integrated health system, may the effect be substantially lessening market competition or going in the direction of a monopoly? So that's the concern. And this gets us back to the St. Luke's and Salzer merger case that we talked about earlier in the class. So a bit of background on the St. Luke's Health System Salzer merger case. St. Luke's Health System created an ACO under the Medicare Shared Savings Program. And along with other efforts to implement more value-based payments, it purchased a lot of practices and facilities around the Treasure Valley and around southwestern Idaho. And as part of that, St. Luke's purchased Salzer Medical Group in Nampa. And the Federal Trade Commission, the Idaho Attorney General's offices, St. Alphonsus Health System, and Treasure Valley Hospital brought a lawsuit challenging the merger as violating antitrust laws, specifically Clayton Act Section 7 that prohibits anti-competitive mergers. And there's a whole lot of facts in this case, but the Federal District Court found that the merger would give St. Luke's control over 80% of the adult primary care market in Nampa, and determined that this high level of market share and market concentration was problematic. And the court recognized that St. Luke's was undertaking a number of activities to increase the efficiency of care by adopting an electronic health record, becoming an accountable care organization, undertaking other efforts to transition to value-based payment, care coordination. But the court concluded that these efficiencies were not merger specific, meaning that the court concluded St. Luke's could have achieved these efficiencies through means other than merging to highly concentrated levels. So the court struck down the merger as violating antitrust law. Of course, there's much more to this case, but hopefully that provides the gist of it. And the argument in favor of aggressive enforcement of antitrust laws to prevent highly concentrated markets includes empirical evidence that shows that the rates providers negotiate with insurance companies tend to go up in highly concentrated markets. The court in the St. Luke's Salzer case cited an article summarizing how large physician groups with added bargaining power can negotiate higher reimbursement rates. And another example we looked at is the rate negotiations between Sutter Health and Blue Cross of California in the San Francisco Bay Area in 2000. In 2000, Sutter Health demanded substantial rate increases from Blue Cross of California. Sutter had enough of the market share to have a geographic lock on the San Francisco Peninsula and higher bargaining power, and Blue Cross of California eventually increased its rates, and insurance premiums went up in San Francisco and in the Bay Area. On the other hand, some other economics research tends to indicate that more fully integrated ACOs will be the most successful in reducing costs, better than ACOs made up of looser networks of individual providers. Here's the same quote from Francis and Rebizer that I showed earlier. As mentioned before, doctors in independent practice may not be able to assume the financial risk associated with value-based payment. They are more set up for direct fee-for-service. Think about it. A relatively small doctor's office wouldn't have the resources to assume the risk for keeping patients healthy, which means they risk not getting paid if patients get sick. They are more set up to provide care and then get paid directly for that. Rather, an employed physician or physicians that are employed by larger health systems will probably better adapt to value-based payment. The hospital or health system can add to their job descriptions work with coordinating care and improving processes. And if they have some guaranteed salary as employees, they are going to be less worried about seeing more patients for fee-for-service payment. For example, in the St. Luke's Salzer merger, the contract said that Salzer physicians would be guaranteed compensation during the first 2 years with St. Luke's that was at least as high as what they got on average during the 3 years before the merger. So you wonder, would this guaranteed salary have given these physicians some breathing room or somewhat of a safety net to more fully adapt to value-based payment? So taking this into account, you wonder whether an actual merger between Salzer and St. Luke's would have been necessary to more fully achieve the potential efficiencies. In other words, one wonders whether the research by Franson and Rebitzer tends to contradict Judge Windmill's finding that the efficiencies the merger would facilitate were not merger specific. In other words, without actually acquiring Salzer and guaranteeing physician salary at a certain level, and then specifically adding care coordination to the job descriptions, could St. Luke's be as successful in getting providers to focus more on patient wellness rather than the number of services provided? By this point in this class, you should hopefully realize that with legal, ethical, and policy issues, there are often competing issues, and that there is often not one clear right answer. On the one hand, from the existing empirical research, we know that with higher market concentration of providers in a given region, the rates that private insurers are forced to pay and also insurance premiums that consumers pay tend to go up. But on the other hand, emerging research also suggests that integrated systems will be most successful in providing cost-effective care and avoiding providing unnecessary and expensive care. And Judge Windmill recognized these competing interests in the following statement from his decision. In a world that was not governed by the Clayton Act, the best result might be to approve the acquisition and monitor its outcome to see if the predicted price increases actually occurred. In other words, the acquisition could serve as a controlled experiment. Judge Windmill is essentially saying that setting aside the requirements of the law, it may very well be that more integrated systems will function more efficiently. Of course, if you limit the amount of competition, you also, with highly integrated systems, please think about how else prices could be regulated.